the Aga Khan Health Service East Africa, shows our vision and our mission. Those are three main pillars on being a premier service delivery, teaching facility, and stake-on partnership initiative. These are footage of Aga Khan Health Service Tanzania. We are present in 13 regions in the country. We have a total of 28 outreach and medical centers across the country. 16 of them are based in Dar es Salaam, as you can see from the map, and we're located in different parts of the city. Our focus is on lab, and these are daycare centers, so we are focusing on lab, but also pharmacy and imaging services. And those are few highlights of what we have in terms of facilities in the main hospital in Dar es Salaam, that is actually close to this conference room. And these are our main specialties and super specialized services. Cardiac program, which is very big. You all understand that Aga Khan is just right now developing also an oncology center, which is going to be addressed in details by Dr. Chua. In Mwanza, we have got a very good state-of-the-art hospital, just upgraded recently to be a regional facility with the list of services that you have seen. This is our lake zone present, and we're in 5 different locations in the lake zone. Those are facts and figures for 2022. We see, as you see, we have almost 1,000 plus staff across the network, 29 postgraduate medical education residents, and apart from that, we see over 1 million outpatients as we speak across the network. We are also, in terms of inpatients, we are almost hitting 12,000. This is last year, 11,000 plus inpatients. In terms of surgical services, we are doing over 5,232 surgeries on an annual basis. This is our ICU in terms of capacity, beds, as you see, a total of 23, as you can see, and they are all equipped state-of-the-art with all the ventilations and all this. These are numbers of rooms in our private wing. We call it the pavilion, which is good to know. We are doing lab studies, 1.7 million in a year across our network. This includes our satellite clinics, but also we do over 103,000 imaging services across the network. This includes X-ray, radionuclear medicine, and the rest. 2.1 million spent over welfare program to support patients who cannot afford the treatment or the cost of treatment. And we have a lot of collaborative projects across the country, and these are main partners, including AFD, Poland government, RWA is a Reconstructive Women International Surgeon, and there are so many other partners across the network that we've been working for the past almost 1 decade now, since we started to upgrade most of our services. Now we can go to the second slide. Hello? Karibu.
Good morning, everyone. My name is Ahmed Jusabani. As I was introduced, I'm a senior consultant radiologist and associate professor of radiology at Aga Khan University. This morning, it's my pleasure and honor to be here in the 10th Tanzania Health Summit. And in particular, I'm most impressed that this time we are talking about health system strengthening in terms of universal health coverage. And I would like to highlight the role of radiology in primary healthcare, ensuring accessibility, quality service, and affordable services for all. Next, please. So we are all aware about universal health coverage. This is a global initiative, and it aims that every person should have access to high-quality essential healthcare services without suffering financial hardships. And I will be repeating these 3 words in most of my slides: access, quality, and cost. And this is what Aga Khan is striving for. The primary health coverage, this is the first point of contact for all of us whenever we get any health-related problems, and it plays a very important role in realizing the universal health coverage. Primary health coverage is a comprehensive and holistic approach to addressing the needs of the individuals and communities throughout their lifetimes. And it is considered to be the cornerstone of universal health coverage, as it not only focuses on management of patients, but also prevention of diseases as well. So, as I said, I will be highlighting these three things, which are the cornerstone of universal health coverage, that is access, quality, and financial protection or affordability. The universal health coverage ensures individuals and communities have access to care. It's not only about care, it is the quality of care that they're getting. And it should be effective, safe, and patient or people-centered rather than the traditional clinical or doctor-centered care that we have been providing. And it has to be cost-effective and efficient in terms of resources. This has been highlighted, and although Lais did not mention that our presence in Tanzania has been since 1929, and we are now here for last 94 years in the country. He talked about the facilities that we have, and our footprint is in 15 regions of Tanzania, from Zanzibar, Dar es Salaam, Pwani, Morogoro, Tanga, Dodoma, Iringa, Mbeya, Arusha, Bukoba, Mwanza. So we have presence in all these places. And in terms of radiology, of the 28 facilities that we have throughout the country, 27 facilities have X-ray and ultrasound services. 2 facilities have CT scan, and there are 2 more which are coming up soon. Mammography is available in one of our services, in facilities. And I'm sure most of you by now will be aware that we are the only Joint Commission International accredited hospital in the country. And most of our outreach centers as well are SafeCare accredited. So this ensures that there is accessibility of the services and the quality of services is there as well. Next, please. Medical imaging plays a great role. It's an integral part of modern medicine. It can encompasses different imaging modalities for X-ray and ultrasound to high-end imaging like CT, MRI, and nuclear medicine. And it is usually used for screening, diagnostic purpose, and now also for therapeutic purposes as well. And it is of paramount importance, and we'll see as we go on, that if you provide good diagnostic services, you can save money from that. So effective, safe, and high-quality imaging is important for medical decision-making and to reduce unnecessary even surgeries as well. Next, please. I would like to show some data from last 5 years, and I've put that this is pre and post PACS. What is PACS? PACS is a pictorial archiving and communication system that we installed in 2018 March. So prior to that, we have data from 2017, and the blue, on the bar graph that you have on your left, we have the blue bars and the orange bars. The blue bars are representing the number of patients that we see in the main facility, and the orange bars are the patients that we see in our outreach clinic. What is interesting here that you can see that we are doing much more work in terms of radiology in our outreach centers than even in our main hospital. So this is to provide the services that the patients need wherever they are, okay? And at the same quality. So we provide these services with the same turnaround time. With installation of the PACS, RIS, and voice recognition system, our turnaround time for all the clinics throughout Tanzania is the same as for main hospital. Over the years, we have managed to increase the number of patients, and last year, as it was shown, that we had about 60,000 plus and almost 40,000 patients. So 103,000 patients totally that were seen in our whole system. 2/3 are in the outreach clinics. And this is without increasing other resources like We have not increased the number of radiologists, the same number of radiologists, but with the system that we have put in place, facilitated by high bandwidth internet, this has enabled us to provide these services. With installation of our PACS system, in 2017, that's the baseline before we installed PACS, our consumption of stationery was 80 million shillings. The following year, as soon as we installed PACS in 2018, we reduced by 20% to 60 million. And in 2019, it came down to about 12 million. So we reduced by 85% our consumption. And not only that, so this is the blue chart is showing the films that we are using. We do not any longer produce films. We provide everything digital. Although our number of envelopes has increased because we are producing more reports, generating reports, and we put them in the envelopes. And also you will see the green graph there, the number of CDs and electronic requirements have increased. But all the printing requirements have dramatically reduced. So we reduce our cost by 85% by introducing this technology and ensure that we can cover all the areas of Tanzania. Next, please. I will not dwell much on that. I don't want to drum for myself that what our department does, but there are a lot of things that radiology does. Let's go to the next slide. So as I mentioned before, that medical imaging has multiple roles. If you have good medical imaging services, you decrease the hospital admissions, you reduce mortalities, unnecessary deaths, but also surgeries which are not required by providing the right diagnosis, and increase life expectancy. So medical imaging saves lives and resources. There are challenges associated with medical imaging, and one is adequate infrastructure. So as we go to the peripheral centers, we have to select right places where we ensure that there is safety of radiation, but also other logistics like having the right electricity and other things associated with medical imaging. Having appropriate equipment that will work in our peripheral centers, because some of these are three-phase equipment and many of the peripheral centers have one phase. Trained workforce is a challenge in this country, but also with all that you need adequate financing if you want to enhance access to services. So our own main radiology department in the hospital supports our polyclinics or our outreach health centers from the time we start to select a site, train in radiation safety and ensure our infrastructure is safe, equipment selection which is appropriate to the place that we're installing, we recruit staff, train the staff in the main hospital so that they understand our expectations in terms of quality. Reporting of images, we support them, that is done from the main hospital. We also have staff capacity building. We have our own departmental CMEs, and by use of Teams and Zoom, we also provide the access to the outreach clinics. And we are continuously monitoring our quality and safety in our outreach and also provide supportive supervision, not when there is a problem, but when we just go when things are going well as well. So if you visit any of our radiology department, we have a quality assurance system, and these are all the documents that you will find in the medical imaging. I know it's a lot, but these are the requirements for the regulatory authorities and our own requirements as an accredited institution. Next, please. So what are the benefits of all this? This ensures that we provide patient-centered care. The clinical outcomes of the patients are improved. We provide safe and efficient work environment for our own staff, but also for the patients who come to us. We reduce harm and dissatisfaction. We meet the requirements of the regulatory authorities, and there's less risk and protection from liability and medical litigation. With this, we are able to provide good maintenance and sustain our equipment with longevity, but also we strengthen community confidence. Next, please. So as we said that universal health coverage is about access, quality, and cost effectiveness. So the benefits that you have is that if you provide services where the patients are, is that they can get the right diagnosis and right treatment in their own environment. This makes them avoid long-distance travels, accommodation expenses, and many other associated expenses as well. Management of disorders, we all know that if you are with your family, the outcomes are much better. You have somebody to take care of you. So accurate, timely diagnosis and treatment decision within your own environment. And of course, the dollar sign. With all that, you reduce the cost of diagnosis and treatment. The largest facilitator that has helped us to ensure that we provide coverage in all these areas is the internet connectivity. This has brought us a lot of advantage with the higher bandwidths, smaller equipment, and larger storage spaces. We don't have now dark rooms, we don't have spaces to store those envelopes of films and all that, and all our data, images, reports, everything is on the cloud. So for next 10 years, we have all that. There are some barriers, but these are not important. So I would like to conclude by saying that the UHC is a good strategy to adopt and guarantee access to marginalized populations. Diagnostic imaging has an important role, as I've highlighted. Integration of universal health principles in primary healthcare will improve access, quality, and cost effectiveness. So the only thing that you have to be careful is to make sure that the diagnostic services that we provide are appropriate to the population that's served. You cannot put CT in a very rural area where the requirement is not high. Okay? So you have to put the appropriate equipment to the population, which is, and also depends on the disease burden in that area. And finally, the human resource should be adequate, and the financing and investment has to be there. Next, please. Thank you. And this is the magic, this is the factory where all the reporting is happening in the main hospital. Thank you so much for your attention, and if there's any question, that's my email.
Thank you so much, Professor Jusabani, for such a very detailed presentation. I knew this is one of my speakers who could spend more time to talk about the department and what we offer. Thank you so much, Professor Jusabani. Please reserve your questions. We'll be having a slot for question and answers from the team. Our next speaker is Dr. Caroline Ngimba. Dr. Caroline Ngimba has joined Aga Khan the last 2 years. She's a pathologist, but also she's the head of medical laboratory and pathology department of the Aga Khan Hospital in Dar es Salaam. Dr. Caroline, please, the floor is yours. Karibu sana. I'm sure she's going to speak up with the speed, but also in less than 10 minutes.
Okay, thank you, moderator, for a wonderful introduction. As I've been introduced, my name is Dr. Caroline Ngimba. I'm a pathologist and also a head of pathology department. Okay, thank you. So we'll go straight and talk about the role of laboratory at Aga Khan Health Services Tanzania in the support of the primary health care. So at AKHST, we have main laboratory, which is located in Aga Khan Hospital, Dar es Salaam. And this main lab is accredited by both SADCAS and JCIA. And at our lab, the services that we provide include hematology, clinical microbiology, clinical chemistry, molecular pathology, and anatomical pathology. I will highlight more on the molecular pathology and anatomical pathology because these are some of the services which are found in few hospitals, both public and private hospitals. Next, please. So when we talk about anatomical pathology, this includes diagnosis through tissue, biopsies from surgical specimen, as well as body fluids. So at Aga Khan main lab, we provide histopathology services, cytology services, as well as immunohistochemistry. So In the process of integration with our outreach center, we do receive referral samples for pap smear, which is used in cervical cancer screening, and we provide results of which our patients can get results while they are at their centers. And also the tissue biopsies from surgical specimen can be referred from these outreach centers, because these services are few in the country, and then through our referral system, they can be processed and results are provided through our outreach centers. We have also the molecular pathology lab, whereby for now we provide diagnosis of the infectious diseases, and we have a large panel as listed in my slides. And in this panel, it covers about 64 pathogens, which range from viruses, bacteria, to some protozoa. And we are the lab that has been approved by the Ministry of Health to do PCR for COVID-19. But also for the future, we are planning to include oncology molecular tests, as we are going to have a cancer center in our hospital. Next, please. So, talking about our Aga Khan Health Services outreach, we have 26 outreach centers and 2 hospitals, which are located in Dar es Salaam and Mwanza. Therefore, in all these centers, we have a functional laboratory with well-equipped equipment. And we have a good referral system which link between these outreach centers and the main hospital. And this center, they have adequate test menu to cover the local clinical needs. And the good thing at AKHST that we have a special pricing model, of which you will find the same test have different price depending on the center. So a test of malaria at Mbagala is priced differently from the same test at Masaki or Mbezi. And to make sure that we have quality lab services, we have implemented what we call external quality assurance in our outreach centers in some of the tests which are being performed there. But also, as it was mentioned, our centers have been accredited by SafeCare. Next, please. We have what we call laboratory information management system, of which our lab equipment have been interfaced with this system. This is helpful because our referral test results can be accessed from the outreach centers with no need of sending the test results. But also, the main hospital can access the lab results from all centers that we are working with, which means even for a patient who has been referred from any of the center, the access of his or her results can be seen. Next, please. So here I will summarize on how does the main lab do support the outreach center labs. First of all, we are involved on the selection of lab sites during construction of these outreach centers. And when it comes to the recruitment of staff, we are also participating on recruiting staff who will be going to this new staff. We also support training, and this involves the training for the new recruited staff who usually are exposed to the main lab for a minimum of 1 week before being dispatched to the centers where they are going to work. And also we have a quality officer who conducts quality management system training to all staff in the outreach centers. We do have the regular supportive site visits, and this visit, we make sure that we check on the compliance of this lab to quality. And this compliance includes on checking on the external quality assurance, and internal quality control performances. And when we find gaps, usually we do what we call the root cause analysis to put action plan in order to mitigate and correct the gap. And again, when we identify gaps on the area of, on other areas, like on the use of machine, we do retraining, whereby by organizing the training with the machine vendors to our staff, and also if there is a need of exposing this staff of the outreach centers to our main lab, we do that. And the other support that we provide to these centers include advising of the type of equipment to be placed. And whenever we have new equipment to be installed, usually we do evaluation at the main lab before sending the equipment to any of the outreach center. So in general, this is how the main lab do support the primary health care through our integrated health system. And even for the services which are required in this peripheral, which cannot be obtained, still through our referral system, it can be possible. A good example is cervical cancer screening through pap smear. We are all aware that cervical cancer is one of the most common cancers in the country. Therefore, through this system, we are able to help people. Thank you.
Thank you, Dr. Caroline. She's really sticking to time. She spent 9 minutes, and thank you for that respect to the audience. She highlighted about the integrated health system of the Aga Khan network, which is quite interesting when you talk about the pricing, differential pricing model that we've tried to adopt across the network in Tanzania, which has a lot of advantage in terms of increasing access to communities in Tanzania to the quality that we are talking about. So this is something so interesting. Today you can see the test of malaria in a center, for instance, in Bunju, which we are charging 10,000, but the same test in Tandika we are charging 5,000. And you have a room also to consult our specialists on the same center with a less cost as compared to what you're charging in our main hospital in Dar es Salaam. Today, to have a room to see Dr. Mvungi, it's 60,000 in the main hospital. But when you stay in an outreach located in Kigamboni, we are charging 15,000 to see the same consultant. So this is, a model that has really brought a lot of changes, and that's why you see the model itself attract a lot of patients walking in, but also bring a lot of trust and confidence because you're going through the same quality standards. And as she said, even our recruitment procedures are also centralized in a way that we cannot abuse the quality and competent staff joining the network. So our next speaker to come in this podium is Dr. Robert Mvungi. Dr. Robert Mvungi is an interventional cardiologist. He has joined Aga Khan way back in 2016, if I'm not mistaken. He's coming from a very diverse background of cardiology treatment. He's trained and he has been working in South Africa before coming back home in 2014 and joined JKCI, where he's initiated all the cardiac treatment, and then now he's working as a private consultant with Aga Khan Health Service Network in Tanzania and a president of Tanzania Cardiac Society. Karibu Chifu, the podium is yours. Karibu sir.
Thank you. Thank you, Stephen, for such a nice introduction, which I don't need to introduce myself. Can you go with my... Okay, I think that is also my introduction. I'll be talking about integrated cardiovascular healthcare service delivery at Aga Khan Hospital, Dar es Salaam. I think it is one of the centers which they have a very well developed cardiovascular care. Next. This is the Aga Khan Hospital. I think this is the main hospital. All of us probably know it. Next. Yeah, as I said, it's integrated has cardiovascular care. In Aga Khan Hospital, cardiology is a unit, it's operated under internal medicine department. And here you can see in cardiology we have kind of divided into two parts. There is a non-invasive and invasive units. And all together they work together as providing services. We have our main invasive center, which is called cath lab, which is more diagnostic and also for therapy treatment. We normally treat in the cath lab. If you have a problem, can be sorted out. We have a non-invasive. We have a well-developed echo lab, where we can do all the non-invasive tests for patients presenting with cardiovascular diseases. We have echo, we have ambulatory blood pressure. We can also do Holter, looking on the cardiac conduction system if you have another problem. Also, we have CT cardiac. I think Dr. Givisani is here. He talked about that. We normally work with the radiology, and when the patient needs an indication of cardiac CT or cardiac MRI, we normally refer this patient, and then we got all the information, and then we have to make a decision on treating this patient. We have our coronary care unit. This is like an ICU, and it's more closer to ICU. When you have acute cardiac condition, which patient needs to be looked closely, we have to admit this patient on that unit, and they can be treated. The patient needs maybe to go to ICU, is just a next door patient can be transferred to ICU and taken care. We have also nuclear cardiology. I think this is a very important part of our care, where we can do nuclear cardiology tests, especially in ischemic heart diseases, and we want to find out maybe how we're going to treat this patient. We normally work on that. But the other important part is emergency medicine. I think in an acute setting, heart attack, that is where our main center of entry in the hospital, where we have a very dedicated team focused on the cardiac chest pain. When you just there, the ECG is going to be done maybe within 5 minutes, 10 minutes, we know there is a problem. If the patient has a heart attack, maybe STEMI, which is a complete obstruction, the patient will be transferred immediately to the cath lab, and then at the same time, we open up the vessel and the patients get treated. This is a combination of all what we do in nutshell at Aga Khan. Next. We are expecting, I think the CEO is here, probably will be listening to me. I think it's going to be expanded, and probably later on, we're going to have a cardiothoracic theater where the cardiac operation is going to be also done, because the setup on the cardiology part is already there. I think this is just an additional service which is not going to be also introduced maybe later on. Next. Yeah, I think when we are doing these services, sometimes you have to have your own system how to evaluate what you are doing. I think if you look on this is this year, maybe next year, I think cath lab, which is the mainstay of the services in the treatment of heart attack and the blockages of the vessels, it is going to be 10 years. We have just done a preliminary analysis. We are looking on the data, what exactly we have been doing on these 10 years. You can see, retrospectively, this is, we are looking on the data. We have found that for this last 10 years, patients which came with heart attack, STEMI, and STEMI, can you play the upper picture? Yes. STEMI, when we talk about heart attack, is the vessels completely blocked. And what is happened that if you look, I don't have a pointer, what's happened that if this vessel is blocked, completely the muscles around this, which is supplied by this vessel, they're going to die. And what's happened that patient can die also immediately, or if this vessel is not open. In this essence, there is a saying, we say that muscle time is muscles. Within 1 hour, if this patient is not sent to the cath lab to open that vessel, there's a consequence that they're going to lose that myocardium. And the patient can develop complication. If this patient will survive, will end up with probably heart failure, will end up with probably arrhythmias, and then with all the complications. What's happened, this is one of our patients, when he came in, he had chest pain, we said it is, what you see here is a stump. It was completely blocked, and then we immediately sent this patient within 10 minutes to the cath lab. We opened up on the lower side. You can see on this image, this was just picked from the ECG, from the symptom of the patient. The patient was immediately sent in the cath lab. This is the cath lab what you are seeing. Going back to our evaluation, what we are doing, we have this kind of cases for these 10 years, more than 319. In fact, I was surprised even to know myself that we have all this such a big number. And we have entered, because we have to get more of the information, we have entered 230 patients who we're going to analyze. But I think also we're going to go even more deeper to see on all this data and see how it happened. This is just a snapshot. And maybe worth to mention that there is another type of heart attack which I haven't really looked on. This is just the serious one, which can cause death and which needs immediate treatment. You can see in our analysis, I think about 16% of patients were younger, 45 years of age. And this is a really big problem in this country. And you can see between 45 to 60, the percentage is almost more than 50%. And probably the age, even 60 still, you are still younger. More than 60, they were 33%. And unfortunately, I'm not gender biased, we see more male than female on this category. And this is also reflected worldwide. Heart attack is more reflected in male than in female because the symptoms in female, they are not direct. Therefore, we have to educate. Probably we are missing a lot of these cases that don't come to hospital because of the symptoms. You can see this is the ethnicity. I just wanted to highlight, to show to you, that it's not only if you are black, you are covered that you don't have a heart attack. You can see the Africans, I think they were more just going like the South Asian. This is including all the Tanzanian Indians, Tanzanian Pakistani. But others, I think probably this was not indicated in their file, but probably they might be falling in this. We have some Caucasian who are coming to visit here, coming as a tourist. We also they fall on this category. And when you are doing this procedure, can you play my film? Cardiology is all film, but we are not movie makers. You can see this vessel was completely occluded. And when we went with the wire, we couldn't see anything. There is other gadgets where you can go and retrieve the clot, you aspirate the clot. This is what you see here on this picture below. This is where the clot was. After removing that clot, then we put a stent, the vessel was open. Next. Next. As I said, that's where we're getting this patient coming to our cath lab. You can see majority of patients just came themselves. Because of chest pain, they came to Aga Khan because they knew maybe there's a mouth of word that if you have a heart attack, go to Aga Khan. Some of them, they came from our outreach centers. They were referred. You can see, this is, we are trying to see how we operate and how this information is going to help us to make our services much better. Next. I'm going not to talk about heart attack management. It needs infrastructure. It needs a system. And this is what we are lacking in this country. Aga Khan is just now giving us a lead that we have to sit down, not only in the private sector, needs to be also gone to the public. We have to have an infrastructure, how we can save life by having a very well-constructed infrastructure on heart attack management system. Next. As I said, I think I have mentioned about the symptoms for female and male, they are different. Next. You can see heart attack diagnosis is very simple. Even in the outreach, it just needs three things. You need to have symptoms, you need to have an ECG showing that you have an heart attack, you need also to have cardiac enzymes. If you have two out of this, and it is indicated, especially if it is STEMI, it's completely occluded vessel, life can be saved, patient can be rushed to the center where interventions can be done. I think this is what we are doing in the outreach. We're training doctors, we are training how to see this patient and refer them expediently that they should come to the center where we can do intervention. Next. Again, this is just a system. Next. You can see in Aga Khan, I think also this, on top of what we are doing now to evaluate what has been happening, we are part of the NCD registry. This is an American registry where we are being evaluated by other institutions outside in our continent, where all these patients coming with acute chest pain, they have STEMI, we enter all the data. Our performance is almost the same as like a big hospital in Seattle or in California. You can see we need to have this availability of these services, and it should be accessible, and we have to have very high care quality so that we can save life, and it should be safe, effective, and timely to save life in a heart attack. We need to have measurable measurements, and that's what we are doing now. We are part of NSDR, so we'll go through those information, and now we are evaluating our 10 years data to see how we can do it. Next. Take your message here. Quality, integrated system, capital intensive. This is very important. Setting up this system needs money. There is no doubt about it. And it is expensive. Who's going to be funding this? It's possible, it can be done. We need also human resources. Mvungi is talking here, tomorrow Mvungi is not here. Who is going to take over? Who is going to continue providing these services? And also we have to have a continuous improving our health delivery, looking on what we are doing, and we improve more. But the last, we need collaboration. Public-private partnership. There is no way you can have a heart attack system without involving all stakeholders. Thank you.
Thank you so much, Dr. Mvungi. It has been again a very well-detailed presentation. I'm very personally, I have to put my interest down that I love cardiology. I'm not a doctor, but it seems to be very appealing enough to know much more about it. Now we have less than 30 minutes. I still have 2 speakers, and my audience need to engage the speakers. I'm going to call my next speaker, Dr. And please, feel okay if I pronounce your name right or wrong. Dr. Masolo is my brother, my friend, but the second name is always a problem when it comes to pronunciation. So Dr. Masolo Sanai is a gastroenterology, but also section head of the gastroenterology services in Aga Khan Hospital, Dar es Salaam. Please, you have less than 6 minutes, and I know you can make it, and give my audience more time to speak. Thank you.
All right, good morning, everyone. I think I've been to take much of your time. Something has happened. Should I continue? All right, all right. So can you take up the next slide? So gastroenterology unit is also part of the internal medicine department within the Aga Khan Hospital, Dar es Salaam. Our scope of service include many, but I will highlight about the endoscopy procedures. As we know, as a gastroenterologist, you have to do some diagnostics, including upper and lower GI endoscopy, some therapeutics, including polypectomy, band ligation, scleral. For those of you who are in this field, you might understand better. But also, we are one of the only center that does ERCP. This is endoscopic retrograde cholangiopancreatography, where we can intervene for many of the diseases that are happening in the biliary or the pancreatic ductal system, whether it is infections, it is stones, or anything that is happening in this system. The other thing, can you go to the next slide? Yes, so now also we have intragastric balloon. Some of you have heard about this. It is also available in our center for those who want to fight obesity. Next, yes. I know it's a global problem. Yes, just to highlight some of the things. And recently we have now started bariatric surgery with the Aga Khan Network Pakistan in collaboration with them. So now we have a visiting surgeon who comes, I think, next in December. Yeah, so those are the various different types of bariatric surgery. Next. So how are we linked to our OHCs? As we said, we have 28 outreach hospitals and clinics. So as in the radiology unit, we are also linked with them through the PACS system, where our endoscopy images and reports also have to be in the same system. So all the clinicians in the outreach centers can also see our reports and the images of the endoscopy systems. So this one can be a good way of giving them feedback, just in case they had referred the patient to us, but also just in case this patient is being attended in another outreach clinic later on, then the doctors have all the information that they need. Yeah. Otherwise, we also do orientation of new staff, those who are going to the outreach centers. We do quarterly CMEs through webinars, and also we have within the department morbidity and mortality discussions. Every patient that has unintended outcome, or in some cases death, we have to discuss. And this one is available through our network. Anyone can join in and listen. So in this way, we can enhance the quality of care that is also happening in the primary health care. Otherwise, our consultants, our doctors in the primary health clinics can also call us just in real-time consultations through phone calls or by extension. Second. Yeah, so as I said also, we have a referral system, either through the online referral form or through the physical form that they can send the patient with if they are sending to the main hospital. And also we have to give them feedback, either through email or through medical reports. And also our medical information system allows the clinicians in the outreach centers to see all the notes, the clinical notes. So the file is online, it is not physical. That means they can see exactly what happens to the doctors. And this cuts across all the other departments, and it ensures continuity of care. Next slide, please. Yeah, otherwise also we do screening camps. We have done this so in Mwanza, in Arusha, and in Zanzibar, where we screen for the various GI and hepatology. We know the prevalence of hepatitis B is around 4%, which is equivalent to that of HIV. So we encourage screening and vaccination, and our last camp was in August this year, where we had screened about 500 residents of Dar es Salaam. Next. Yeah, so we have several quality initiatives within the endoscopy unit. One, we are establishing now an endoscopy database for research purposes, which will serve the same way as Dr. Mvungi is describing, to be able to analyze your data over time. And for monitoring and evaluation, we have several KPIs that we are working with. Every time, every month, we have to see how much time our patients have to wait before they receive our services, again, compliance to time out, CECO intubation rate. These are more specific to endoscopy. Adverse events related to sedation, again, disinfection compliance and compliance to documentation. All these are JCI requirements which we have to comply. Thank you.
Thank you, Dr. Masolwa. This has been a really good presentation, short and clear, and we don't need even to repeat what he said. The most important part of the presentation is also to know unique areas that the hospital is actually invested in terms of facilities, but also himself by performing all these ERCP procedures and now gastric balloon, which is quite interesting. And I'm going now to the next speaker and last, and just before welcoming him in this podium, Dr. Harrison Chua is an oncologist, and he's the medical director of Aga Khan Health Service Tanzania, but he also is a manager of the Tanzania Comprehensive Cancer Project, which is a 4-year project coming to an end this December. And he has so much interest and a lot of works done on clinical oncology, particularly in assisting patients with different challenges on cancers. And I'm sure in this place I see some of the stakeholders on that aspect. Dr. Chua is also going to talk a little bit about the clinical governance, and I request him not to spend more than 10 minutes with the respect of the audience. Please, just mark the time. Dr. Chua, karibu sana.
Thank you so much. I'll try to manage within 10 minutes. Can we go to the next slide? Yeah, so I'll talk more on the primary health care and in relation to oncology care. So by definition of the primary health care is the whole of a society, the way the first encounter of a person in the community with the healthcare system. That's all it means by healthcare, primary health care. Now, how can we enhance that? That is what the Aga Khan health system is trying to do. And as you see, all my colleagues were showing how we are trying to bring down the tertiary level care to as close as possible to the community. And we all know there are some challenges that are involved, so that's what we're going to discuss. You can't bring everything down, but there are some basic things that you can literally trickle them down to the community. And next slide, please. And these are the elements that you should consider in the primary health in terms of education, and this is awareness and the health education, sanitation, drug availability, treatments, prevention of endemic diseases, immunization, and maternal and child health. Next slide, please. Now, the Aga Khan Health Services System Tanzania has this vision. The vision of it is to be the premier, one, premier, two, teaching, three, tertiary healthcare system in Tanzania. I've blown out or glowed healthcare system, meaning that the way we operate, we don't operate as a hospital. We operate as a healthcare system. And it's a system that is parallel and complementing the government healthcare system. So we are not competing, we are not trying to disregard the national healthcare system that is there, but we're just there to complement the national healthcare system. And you will see in my next presentation what we mean by that. So can you go back again? Yeah. And our mission again is to provide, again, what Professor Gisamani mentioned, the three components of universal health coverage: access, quality, and cost. And you can see they are all mentioned in our mission, that to provide accessible, high quality, cost-effective healthcare services to the people that we serve. Next slide. Now, in terms of oncology, I think as a country, for the last 10 years, we were guided by this document, the National Cancer Control Strategy, that ended last year. And if you ask me, this was supposed to be the Bible of all oncologists in the country and all policymakers towards cancer, that we should follow this, because anything deviating from this, it means you are going astray from what the government has put in as their priority and as their strategy. Now, looking at this document, you'll see that the main 4 bullets that I've put down there, that to integrate cancer into existing healthcare delivery system, to reduce the incidence and impact of cancer, to enhance quality of life for those patients that are living with cancer, and to reduce inequalities with respect to access to cancer care services. Right? Next slide. Now, with that in mind, you have to come to what we call the cancer care continuum. The way cancer you should care oncology patient is through this cycle, this continuum. You have, number one, the best thing to do, the light green one. Men are color blind, so please excuse me if my light green is not the right one, but prevention should be our main focus. And under prevention, if we're able to prevent, and for those that we are unable to prevent, then we should do detection. And preferably here we are talking about early detection. All right? And then, once detected that there is some abnormalities, then we are supposed to get the accurate diagnosis. And after diagnosis, then we have to give the appropriate evidence-based treatment to these patients. And after treatment, there should be a survivorship program. And this is very important, and I think it's something that we take it so lightly. And I think for the last 10 years, we were very behind this, because we didn't have so many survivors. But now, as the number of survivors are increasing, this is one of the very most important components that we should consider while creating our programs. But we should also know, for those patients that are found on stage 4 that are not curable, and they go to end-of-life care, then we should consider there is end-of-life care, and that is what I've put the blue arrow there. So this is the continuum that, as an oncologist, as a policymaker, as a hospital administrator, health system administrator, looking into cancer care, this is what we should focus on. Now, on the right side, I've put the challenges in our setting that are there. Number one, most of our patients come at a very late stage, so it means we really need to work on prevention and detection. This has to be one of our biggest focus. Followed by the next bullet on our challenges is the limited access to basic high-quality services in all competent, especially in terms of diagnosis and treatment. Then, lack of critical oncology equipment and the infrastructure, together with community knowledge and awareness and other, and of course, the biggest thing that we know is the lack of radiotherapy machine. Now, as we were developing our oncology program, which started in 2014, we looked into these 4 components: infrastructure, capacity building, community level engagement, research, and partnership. And we have been following this for the last, this will be now our 9th year as the AKHST. And then the program, or the project that Olai's mentioned, that I'm managing, the Tanzania Comprehensive Cancer Project, is also based on these 4 objectives. Now, because of time, if you allow me, Olais, can I skip the next, go next? Because I was just expanding on those components. Next. Yeah. No, okay, one slide back. I just want to yes. Now, Now, considering the primary healthcare setting, I think this community level engagement is more pertinent in our discussion now. And in our project, what we've done is we made sure that we engage through community leaders, through faith-based organization, through women groups, right? We go to community, to prayer houses, right? So it's in a way of making sure that we engage the community to raise their level of education and awareness on cancer so that they can show up for early detection. They can also agree and comply to prevention, for instance, hepatitis B vaccine and the human papilloma virus vaccination programs that the country has rolled out. So all of this is mainly focused there. What Aga Khan has done so revolutionary is we've done what we call a saloon project that you can see there, put the scissors and the comb. We've engaged some saloons. Currently it's only Dar es Salaam and Dar, whereby the owners and the saloon hairdressers have come for training. We've trained them on basic knowledge of cancer, and then they are now like ambassadors. So instead of them wasting time in saloon talking about, Diamond, Alikiba, blah, 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 and what they see in social medias, they talk on more sensible things like, how did you do a pap smear? Have you gone for your mammogram? Why should I do that? And then she's able to explain what is the importance of doing such tests, right? The same, have you told your husband to go and do a prostate PSA test, right? And then the other important thing that I also wanted to mention that is also revolutionary is you can see that there's a van there. Next slide, please. Well, I know the place, but please, can I talk about this? Thank you. So we have integrated our oncology program with another project called the KFW project, whereby we have these mobile vans, these mobile clinics, that we are able to take them to remote areas. And with these vans, we are able to screen women and men. And what we were surprised is the turnout of men actually now is outpacing women. And the good thing is that if a man comes, gets his prostate PSA test done, if they have an issue, we have an ultrasound machine in the van. We also do a scan, and then we refer for further evaluation. He immediately goes home and brings back his wife. Says, no, I want my wife to be screened. The same way happens for women. Once they hear that there's also prostate screening. So I think with this, with the COVID vaccination, the integration of it, thank you Teresia, she's there, I think I've seen the numbers are so high in terms of screening. Next slide. Yeah, next slide. So I'll go to my next topic, which is more on about, next slide, yes. I think we've seen this slide, but I want to, I just want to focus on things. I think he introduced me as a medical director, all right? And you've seen how big our institution is, and you've seen what Dr. Masolo does, what Professor Jusabani does, Dr. Caroline, Dr. Mvungi does. If we don't have clinical governance, these guys will operate as renegades, they will operate as headless chickens, all right? We will not have order, all right? Now, so to ensure that everyone is complying and everyone is doing everything that is ethical and professional, you need to have a very robust system to ensure that things are running smoothly, right? Now, going to our vision, that being a premier. Now with premier, this is what we talk about, quality, making sure that we give quality. And the only way you can benchmark your quality is for accreditation. You cannot say you're offering quality and safe healthcare without benchmarking with an accredited standard. Which standards are you using? Are you comparing yourself maybe with a lower level? So for us, we've gone with, for the main hospital, we've gone with the Joint Commission International, which is an American system of quality accreditation. And I think to me it's the top in terms of all healthcare qualifications in terms of standards. Then for our outreach facilities, now as here we are talking about primary health care, to ensure that even in our outreach facilities, they are also providing utmost care, we have gone with safe care accreditation. And our lab has gone with SADCAS accreditation. Teaching, I think we are part of the Aga Khan University. So as Lice mentioned, we have resident postgraduate medical education programs. We also host interns, both medical interns, lab, pharmacy. At the moment, those are the ones that, and together with nursing. But also, most important is also the population health program that we have. And this is where, again, we go into, to the community. Our PPP, our private-public partnerships. We are strong advocates of partnership, private to private, but together with public-private partnership. We are advocates of this. My CEO lives and breathes by partnerships. And we've demonstrated with projects, and I will show you some of the projects that we do. And again, in terms of integration, because we all know part of the primary health care is integration. We operate on a hub and spoke model to ensure that there is continuity of care. Our outreach clinics feed into our main hospital. So there is continuity and we ensure that there is integration. Next
Dr.
slide.
Chua, I'll stop you from there. There's no way we can leave the audience now without having at least a few comments to what I respect. I'm so sorry for this because I'm getting pressure. I'm part of the steering committee for the Tanzania Health Summit, and they are telling me I'm breaking the rules, so I cannot. Now, this is a special time for our audience, and I may request somebody to assist to just pass the microphone to. Please, if you have a question, comment precisely for seconds. We have my CEO, Mr. Sao Conte. Yeah.
Thank you very much, all eyes. Sorry, I have to come here. I'm sure you will not stop me, right? So I just want to thank this wonderful team. Can we give them a big round of applause, please? I don't want to repeat what they are saying. The topic is universal health coverage. That is happening in Aga Khan. Through our integrated health system, which you have seen, time doesn't allow them, but there's so much happening in community engagement. There is no universal health coverage where there is no community engagement. What percentage of population is coming to our health centers, no matter how remote? Very few. The majority of the population are in areas. The model of going to reach them at community level is the solution, but go with the right formula to be able to ensure access at that level, and then walk through the health facilities, through the integrators, technology, healthcare professionals, training, and all the others, including leadership and management. And that is a model that we would like to sell to anyone who is willing to come and demonstrate. One aspect is the training center. We are open for any institutions. A lot of hospitals are coming, looking at our customer care, looking at our IT systems, looking at all levels. We are very open. What is that private experience of Aga Khan that can be transferred into any other NGO, faith-based, government? We are very open to that. So, Ongerani Sana for the good presentation.
Thank you. Thank you so much, Mr. Sao. This is the first time I see Mr. Sao making a 1 minute presentation for the rest of my life. Karibu sana. Chief, majina yako na taasisi unatoka na a question to the
Okay, my name is Omari Buguyu. I'm an Assistant Director for Non-Communicable Diseases from Ministry of Health. Few issues of concern. One, you have a lot of good work in Tanzania, and it is a prestige to be to receive services at Aga Khan Hospital in this country. So, congratulations for that. That shows that good quality of care that you're providing. However, for my colleagues Harrison and Dr. Sisao, you are not very strong on mental health issues, so please invest on mental health because it is the biggest problem in this country and there's no quality mental health services in Tanzania, so we are asking for that. Second one is we will also have a national NCD conference in this country starting on the 1st of November here, and the chief guest will be Prime Minister of the United Republic of Tanzania, and I've seen all you presented is all about non-communicable disease. Could probably ask for the plenary session because we are doing a good work. With this plenary session, it is very difficult for many people to understand what is going on. So please ask for a plenary session, but we will charge you.
Okay, no problem. Thank you. Mental health, yes. Important aspect. It's a missing gap, and that's something we've started working on, and we have started developing partners. You cannot be good in everything, but you need help on areas where you need to reach to what you call an integrated health system. One of which is in the mental health aspect, which is now being molded into our neuroscience program, and that's a program on development. Thank you.
Thank you, Mr. Sao, for responding to that. Then I'll start picking the question from the backside, and I'll come back to you. Thank you. I don't want to take the front seaters only. Let's hear from...
Thank you very much. Just a very short question. My name is Dr. Oliver Henke. I'm a hemato-oncologist. I worked with Dr. Harrison for quite a long time when I was at KCMC. Very impressive what you're doing at Aga Khan. It's really, with the outreach program, I see that radiology results are so important if you transfer them, let's say, to Bukoba because somebody got a CT scan there or even ultrasound, and you have the consultants in Dar es Salaam who are giving a correct report on that. Same for cardiology diseases, for lymphoma, let's say, which can be quite complex in the laboratory. Now my question is, do you provide also supportive supervisions to the mostly young doctors in your outreach departments if they have a very complex case and they need a specialist to see the holistic approach? Is that also what you offer to support them?
Thank you. Dr. Chua.
Yes, Oliver, that is what we normally do. And there are two options. There is online, real-time consultation, which means they can just pick up a phone because we're all connected by extension. So they know my extension, they can just call my extension, and then we can discuss that case on real time. So if it's an imaging issue, we can just pop up the image and we can discuss the image while we're there. If it's on the pathology issue, I think it's the same. If it's on management part, it's the same. Yeah, maybe if you want to add anything, Prof. Yusufa. Yeah, we do offer that online. Yeah. I just want to add, for urgent care, which is like for patients with chest pains and for patients with trauma. So we do have urgent care in our OHC, some of our OHC, not all of them, whereby we have a camera mounted. And we have trained that resident medical officer there on urgent care. Now can stream live while attending that patient and can request assistance real time with the emergency team at our accident and emergency department. So they are communicating with the emergency physician. And we've done that, and we've been able to even, some of patients, for instance, from Zanzibar, we get a lot of patients with STEMI from Zanzibar who come and they are within the golden hour. We tell them, no, this one immediately bring, and they go straight to the cath lab. From Mwanza, we tell them thrombolize there first, and then they bring them by air. So it really helps.
Thank you. One last from here. Sorry, because of time, this will be the last question, and we close up from the team. Karibu.
Thank you so much. Dr. Pius from Pure Raj. I extend my gratitude to every one of you. You have done a very wonderful presentation, and I think Aga Khan is one of the heaven on earth hospital in Tanzania, I can say. And everyone was trying to elaborate how we have tried to bring Aga Khan healthcare services to the community. So we at PORAG, we are just working with a very big and large number of people at the lower level. And currently the government has constructed a good number of healthcare facilities. So as you have said in every presentations, you are doing the outreaches. You have almost 28 outreach facilities. So as a part of the good practice that you are doing in Aga Khan, we wish that you move from your higher level, going to the district hospital, the health center, the public one, to build and to share the experiences, what you are doing through capacity building and training and so forth. Otherwise, thank you so much.
Thank you so much. And I'm now closing with my speakers. A comment for 10 seconds. And you pass it over the microphone without returning here, please.
Again, good afternoon, everyone. Thank you very much for all of you for your attendance. I think it has been a good session that we have highlighted some of the activities that Aga Khan Services is doing in Tanzania. I hope this is a learning session for all of us to understand some of the things that we can do more in terms of collaboration. Thank you.
Good afternoon. Thank you again for your attention, but also if you found anything that we are doing interesting, please feel free to contact us. And whatever we can support, collaborate, train you, this will be free of any cost. And I know my CEO is here, he will not kill me for that. I'm ensuring you, whoever you send them to us, we will train them free. Whatever systems, whatever you want to learn, there will be no cost implication for anyone. Thank you.
Good afternoon. Thank you everyone for your attention. And just my message is that you have heard of what we are doing. So please share the news. I know there are some, they don't know what we are doing. So you can share what you have heard. Thank you.
Yeah, I would like to thank everybody who was attended this session. I think it was wonderful. But the one thing which I need to emphasize is interventional cardiologists. We in the cath lab, we cannot do without collaborating. Our patient comes from various places. I think my emphasis here is collaboration, collaboration, collaboration. Thank you.
Yeah, to me, I'll just close with these remarks. What we've displayed here and demonstrated here, and all the speakers here, we're all Tanzanians. So it doesn't mean that these things come from abroad. It means we are capable of doing it, right? And what I wanted to say is we just need to have a vision, strong leadership, and also the commitment and passion to do what you can do. You could see how Dr. Mvungi was presenting, very passionate about what he's doing. Professor Jusabani, Dr. Caroline, and Dr. Masola. So I think those elements, it's possible. All right, so this was not, what was demonstrated here is not in Europe, not in Kenya, it is in Tanzania. So it means it is possible by us. Sawa jamani?
It is possible by us. Thank you so much for listening, and I'm so sorry if I miss out to give you an opportunity to speak during this interactive session. Next time is 2024. We will meet again for further discussion. Asanteni. We have a van, I've been reminded, outside. Our mobile, screening van is outside. You can just visit and see how that van has been equipped and what can be actually offered within. Yes, it's going to be there for 1 hour, so just pass by and see what is happening. Thank you.